morning everyone. I am Dr. Dipti Dhavikar from UNMICRC Institute of Cardiology and Research Center. Today we will be discussing about point of care ultrasound for cardiac anesthesiologist, that is also called as POCUS. Point of care ultrasound is the use of portable bedside ultrasound imaging for a variety of expeditious clinical assessments or as a guidance for multitude of acute care procedures. It is used nowadays so much so that it is also called as 21st century stethoscope. Ideally, POCUS use in clinical management should be goal directed, rapid and reproducible. In certain clinical contexts like pneumothorax or hemidiaphragmatic paresis, POCUS is superior as compared to other diagnostic modalities. Now coming to first application of POCUS, that is airway ultrasound. Airway ultrasound is useful for identification of various airway structures such as cricothyroid membrane, tracheal rings, cricoid cartilage, thyroid cartilage and hyoid bone. In difficult airway scenarios, especially for cricothyroidotomy, this is of very much use. The utilization of ultrasound for pre-procedural identification of tracheal rings as well as pre and paratracheal anatomy of blood vessels is very helpful in assisting even with percutaneous tracheostomy. And one more application is for performing airway blocks to facilitate awake fiber optic intubation. So here you can see the placement of the probe on the neck and the corresponding structures which can be appreciated, that is the thyroid cartilage, cricoid cartilage and the first tracheal ring. So cricothyroid membrane can be easily seen for performance of emergency cricothyroidotomy. It is also used for confirming correct placement of endotracheal tube and to differentiate between endotracheal and esophageal intubation. So in the first picture you can see correct endotracheal intubation, which is represented by the bullet sign, which corresponds to a single air mucosal interface, whereas in the next picture you can see esophageal intubation, inadvertent esophageal intubation, which has two air mucosal interfaces suggesting a double tract sign. So the correct intubation suggests bullet sign, whereas the esophageal intubation is the double tract sign. And also in correct endotracheal intubation there will be associated lung sliding, whereas in esophageal intubation there will be absence of lung sliding. A meta-analysis by Gottlieb et al., which included 17 studies and a total of 1,595 patients, showed transtracheal ultrasonography was 98.7% sensitive and 97.1% specific in confirming endotracheal intubation with a mean time of just 13 seconds. And there are certain distances which predict difficult mask ventilation and difficult intubation. There is the skin hyoid bone distance, which was found to be predictor of difficult mask ventilation, and the epiglottis to vocal cord space distance, which was shown to correlate with the Cormack-Lehane gradient. It is also a valuable and reliable adjunct in cardiac arrest to confirm ET placement, where ET CO2 may be anyways low because of low cardiac output, and also for estimation of the correct cricoid pressure during rapid sequence induction. So this is just a summary of application of POCUS in airway to identify structures like cricothyroid membrane, cricoid cartilage, thyroid cartilage, hyoid bone and tracheal rings and esophagus for procedures like cricothyroidotomy, correct application of cricoid pressure, airway blocks for difficult airway assessment, percutaneous tracheostomy, and for identification of correct ET tube placement. Second application is for gastric ultrasound. So evaluation of fasting status or assuring that adequate gastric emptying has occurred can be challenging in certain scenarios like patients with altered mental status or certain chronic medical conditions like gastroparesis, diabetes or chronic renal failure and liver failure. So this gastric ultrasound allows for identification and measurement of gastric contents based on the antral cross-sectional area with accurate assessment of gastric volume and contents in both supine and right lateral decubitus position. So this is how we perform the gastric ultrasound. So you can appreciate the antrum and liver shadow, and this is the probe placement. So basically if the gastric content volume is less than 1.5 ml per kg, then the risk of aspiration is very less, whereas if it is more than 1.5 ml per kg, then there is more higher chances of aspiration. So the anesthetic plan can be tailored accordingly. Now coming to very important application of POCUS, that is lung ultrasound. Lung ultrasound involves the study of air fluid interfaces in the lungs as well as the interpretation of ultrasound artifacts. Different transducers such as phased array, convex, microconvex or linear probes are being used for lung ultrasound to optimize the artifacts based on lung pathology to be determined and the patient's body habitus. So basically the lung is divided into 6 or 8 zones for focused lung examinations, with transverse scanning recommended in areas of specific interest for further evaluation of pathology. So POCUS of lung is indicated to evaluate dyspnea, hypoxia, hypotension of any cause, thoracic trauma, pleurisy and chest pain. So these are the zones in which lung is divided, and the examination is carried out serially in each of these zones. Normal lung ultrasound mechanics. Normal lung aeration is basically characterized by lung sliding, which is described as movement of parietal and visceral pleura sliding against each other at the pleural line. Normally, the lung parenchyma will have a profile pattern seen as regular repetitive horizontal reverberation artifacts arising from below the pleural line. When air is replaced with fluid, the image will show B lines, which are comet tail artifacts, which are vertical hyperechoic lines arising from the pleural line and fanning downward all the way to the bottom of the screen. So here in the first picture you can see the horizontal reverberation artifacts, which are A lines, which is normal lung, whereas on the right side of the image is the pathologic lung, okay, where there are B lines fanning out right from the pleural line down towards the bottom of the screen. So this is M mode interrogation of the lung. So you can see the lung sliding basically, which appears as the grainy appearance of the normal lung, and this is also called as seashore sign. The chest muscles, chest wall muscles basically comprise of the upper area, and the grainy appearance, fine granular appearance which you can see is the normal lung, and the white line is the pleural line. Now coming to abnormal lung mechanics, when the ratio of fluid to air content increases, the number of B lines increase in the lung zones accordingly, resulting in a B line profile pattern. The presence of B lines, however, rules out pneumothorax, that is important. Interstitial lung disease and pulmonary edema may be indicated by the number and distribution of B lines or lung rockets in each zone. Less than equal to 3 B lines in each lung zone may be considered as normal. Absence of lung sliding in a particular lung zone should raise suspicion of pneumothorax. The presence of lung point, which is defined as appearance and disappearance of lung sliding with respiration at a particular point, which is equivalent to M mode stratosphere or barcode sign, is characteristic and pathognomonic for pneumothorax, which is reported with reported overall sensitivity of 66% and specificity of 100% for diagnosis of pneumothorax. It is highly specific. So in this slide you can see the lung point, where the normal grainy appearance of the lung is changed to a straight pattern. Okay, so that is normal is seashore sign, and on the left side of the slide is the static lung, where there is no lung sliding can be appreciated. So that is the stratosphere or barcode sign, and the point at which both these zones meet is called as a lung point. So this point is highly specific for pneumothorax. If this is present, then you can be almost sure that there is pneumothorax. This slide again shows the same thing with chest wall motion and with pneumothorax. The posterolateral alveolar pleural syndrome, that is PLAPS point, is the lowest point in the lung that should be investigated with a curvilinear probe to rule out pleural effusion or consolidation. The detection of PLAPS point indicates consolidation or effusion at the lung basis, while absence of PLAPS point suggests other pathology at lung basis. There are again two signs which need to be looked for. First is a spine sign. Normally what happens is the spine above the diaphragm is not visible, but if there is fluid at the bases of the lungs, then the spine will be visible through that fluid, that is called as spine sign. And with normally aerated lung, the lung moves downward into the abdomen with inspiration, that is called a curtain sign. In the presence of pleural effusion, however, this curtain sign will be absent. So this is the PLAPS point where the curvilinear probe is placed, and the corresponding picture you can see is depicted down. Okay, that is the lung which is highlighted in red. That is the lever shadow, and spine which you can hardly see, and that is a diaphragmatic shadow separating the lever from the lung. So here you can see this is the same PLAPS point where you can see the pleural fluid, and the border of the lung can be seen. This is the spine sign. Normally what happens is the spine is not visible, as you can see on the left side of the image. On the right side with pleural effusion, the spine above the diaphragm is clearly visible. This is the curtain sign. Normally what happens with deep inspiration, the diaphragm moves downward and the lateral part of the diaphragm, which is depicted by white arrows, is usually not visible. But with fluid at the bases of the lungs, what happens is there is no curtain sign, the lung does not come down. So the lateral portion of the diaphragm is also visible with deep inspiration. It is called a positive curtain sign. Another pathology is the air bronchograms. Dynamic air bronchograms signify consolidation, while static air bronchograms indicate atelectasis. Lung ultrasound is also efficacious in diagnosis of lung parenchymal diseases while enabling a better understanding of heart-lung interactions to assist in ventilatory management. Lung ultrasound can also be used for confirmation of double lumen tube placement during lung isolation maneuvers. So this is a short flow chart. If lung sliding is present, then it rules out pneumothorax. If it is absent, then you can suspect pneumothorax. If lung point is present, then it almost confirms pneumothorax. So M mode lung ultrasound, if seashore sign is present, then it is a normal lung, whereas if it stratosphere or barcode sign is present, that indicates pneumothorax. This is a decision algorithm for lung pathology using lung ultrasound. This is also called as blue protocol. So you first of all you see for lung sliding. If lung sliding is present, then you see for what pattern the lung is depicting, whether it is A line pattern or B line pattern. A line patterns indicates normal lung. So the lung parenchyma is essentially normal. So you can look for DVT or any other causes. So you can do a DVT scan. If it comes out to be positive, then it is pulmonary embolism. If it is negative, then you look at the Plep's point. At Plep's point, you can find out if there is any consolidation or any effusion. So it goes in favor of, if it is positive, then it goes in favor of pneumonia. If there is no Plep's point, then it more likely goes in obstructive lung disease after ruling out other causes. If it is B line pattern, then it is obviously pulmonary edema. And if pneumonia is present, then it could either show A, B or C pattern. However, if lung sliding is absent and there is B line pattern, then it likely goes in favor of pneumonia. However, if lung sliding is absent and A line pattern is present, then you should see for lung point. If lung point is present, then it is pneumothorax. If lung point is absent, however, the patient will need further investigations. So this is in brief what all conditions we can diagnose by using lung ultrasound, like pneumothorax, CHF, ARDS, pulmonary fibrosis, obstructive lung diseases, pulmonary embolism, and diaphragmatic paralysis. Now another important application of ultrasound is diaphragm ultrasound. The diaphragm is the core muscle of respiration innervated by phrenic nerve and normally descends caudally and increases in thickness with inspiration. So in cases of respiratory distress, lung ultrasound along with diaphragmatic ultrasound assessment are useful to rule out potential etiologies like pneumothorax and diaphragmatic paralysis, like post brachial plexus blockade. So diaphragmatic excursion during deep breathing normally is about 6 to 7 centimeters. Typically is assessed by Doppler M mode, and but may be challenging at times on the left side due to air in the stomach. So basically what is done is M mode interrogation is done, and the diaphragmatic thickness at the end of inspiration and the thickness at the end of expiration is measured, and the diaphragmatic thickening fraction is calculated, which is the thickness of the diaphragm at the end of inspiration minus thickness of the diaphragm at the end of expiration divided by thickness of the diaphragm at the end of expiration into 100. Normal thickening fraction is about 30 to 96%. Now coming to focused cardiac ultrasound, so this is also another important application. In hemodynamically unstable patients, focused transthoracic examination, that is FOCUS, is used to evaluate global and regional left and right ventricular function, to assess for any valvular dysfunction and to identify presence of any hemodynamically significant pericardial effusions. Specific cardiac pathology easily recognized with FOCUS examination includes certain valvular lesions like AS, dilated cardiomyopathy, pericardial tamponade, hypertrophic obstructive cardiomyopathy with dynamic LVOT obstruction, endocarditis, and pulmonary embolism. So these are views. These are very much similar to the transthoracic echocardiography which we do routinely. So basically a parasternal consisting of parasternal long axis and short axis view. Then you can just do a pleural scan to see for any collection, then a apical 4-chamber view and subcostal views and even suprasternal views. Focus most commonly is performed with a low frequency cardiac phased array probe, with patients typically placed in supine or left lateral position to best optimize the imaging and acoustic windows. Basic focus views can be used for assessment of cardiac pathology as well as quantitative assessments of cardiac function. Focus is a useful tool for determining the etiology of unexplained hemodynamic instability as well as for guiding clinical management and interventions. Focus is particularly helpful in detecting right ventricular dysfunction and regional wall motion abnormalities following ischemia in patients presenting with acute coronary syndromes. Massive pulmonary embolism and cardiac tamponade, which are potentially life-threatening complications, are potentially devastating perioperative complications in which focus provides a rapid diagnostic confirmation to guide immediate life-saving treatments. So, this is especially important in postoperative ICUs. Valvular stenosis, regurgitation, left and right ventricular dysfunctions, any cardiac masses and cardiomyopathies can be quickly assessed and when relevant quantified with a focus examination. Focus can also be incorporated in performance of ACLS without interrupting the performance of standard chest compressions, with subcostal views best for facilitating this indication. Adequate images may be obtained during brief 10-second periods when the compressions are anyways interrupted to assess the underlying cardiac rhythm and pulse. The use of focus in these settings also enables clinicians to diagnose potentially treatable and reversible causes like pulmonary embolism, tamponade, and severe LV dysfunction, and to guide further therapeutic interventions. This is just a summary of the focus. Another important application is for vascular ultrasound. Vascular ultrasound with linear probe commonly is used for placement of central venous, arterial and peripheral IV catheters. Focus examination aids in assessing the volume status as well as central venous pressures or right atrial pressure estimates. And can be obtained by measuring the IVC diameter, respiratory variation and collapsibility index. So, another important score which comes into picture at this point is the VEXA score. If the IVC diameter is more than 2 cm, the use of combined hepatic, portal vein and renal vein pulse to Doppler assessments as a part of venous excess ultrasound, VEXA score, can be done to evaluate the volume overload and systemic venous congestion. The severity of VEXA score is used to guide for fluids, inotropes, vasodilators and diuretic management. Measurement of the right ventricular outflow tract velocity RVOT-VTI with focus when combined with VEXA scan enables global evaluation of the RV function, and when dysfunction is present, its effects on the systemic organ congestion. So, this is the VEXA score which involves IVC measurement and collapsibility index measurement, then hepatic vein, portal vein and renal vein Doppler by using pulse wave Doppler interrogation, and accordingly the scores are 0 to 3. So, a score of 3 indicates severe congestion, whereas VEXA score of 0 indicates almost no congestion. So, vascular ultrasound applications can be used for difficult central line, arterial line placements, for assessment of volume, status of the patient, for VEXA scan assessment and a venous scan for DVT. Another application is for regional anesthesia. So, all the blocks which we perform can be performed with the help of ultrasound like PECS, serratus anterior plane block, erector spinae plane block. Another important application is focused assessment with sonography in trauma, that is FAST. FAST is commonly used diagnostic modality in trauma patients to evaluate for intra-abdominal fluid as well as a guide for surgical interventions. In the postoperative setting, FAST can be used rapidly for assessment of intra-abdominal fluid collections in the workup for hypotension. So, these are all the quadrants which we scan, right upper quadrant, left upper quadrant, and there is one more term which is called as extended FAST, EFAST, which includes lung ultrasound as well as cardiac ultrasound. Last application is in POCUS in critical care settings. It is especially useful for evaluation of patients receiving mechanical cardiac support for cannula repositioning or setting changes, or RVAD for RVAD insertion. Then for fluid resuscitation, combination of lung ultrasound, IVC ultrasound can be used for assessment of volume status of the patient. Lung ultrasound is also helpful for evaluation of respiratory failure and can diagnose acutely and guide treatment for wide range of lung pathologies including pulmonary edema, pleural effusion, pneumonia and pneumothorax. Lung ultrasound can aid in identifying the need for postoperative ventilatory support. An abdominal POCUS as a part of FAST. Abdominal ultrasound has also been used to measure abdominal aortic aneurysm diameter and to diagnose aneurysm rupture. and lastly for vascular ultrasound. Now coming to limitations of focus. Image acquisition requires skill and training. Understanding the sensitivity and specificity of each focus application in comparison to other standard techniques plays a key role in successful application of focus for diagnostic purposes. Thank you.